I'd like to thank the organizers for the chance to argue against our society guideline. It's excellent. So, I mean, Athos already summarized a lot of this very well in a very reasonable way. But I think one thing I'll touch on is a little bit this issue of low trauma and vertebral compression fractures. Does low bone mineral density predict these? But more importantly, does DXA measurement of bone mineral density really reflect how strong your bones are? And is it really a good measurement of what your risk is for future complications of low bone mineral density? Well, in other words, as he said, you know, DXA is about $150 and you get what you pay for. So we have a few options to screen for risk of fractures. You know, DXA is certainly what we use in practice, and that's because it's fairly precise, it's convenient, very little radiation, and fairly inexpensive. There are other techniques, quantitative CT scan, that are probably much better measures of bone strength, but they're quite expensive. There's a lot of radiation exposure, and certainly not ready for prime time for routine clinical use. So I took the liberty of taking a couple of quotes from the guideline. So this is directly from our guideline. All children with IBD who can lie down for at least 15 minutes should have a DXA. So that's every kid in America, right? You know, particularly if they can play a video game while they're getting their DXA, they're up for it. And in fact, what they're testing at CHOP now, which is probably the most reasonable intervention, is you just stand on a plate that vibrates for 15 minutes and increase your bone strength that way. And therapeutic intervention should not be instituted on the basis of a single DXA measurement. So why did they say this? Well, it's because there's some limitations of DXA. There are many properties of bone that affect its resistance to fracture, and really DXA is not very accurate in terms of determining this. So this is one study that was done in a cohort not just of IBD kids, but 200 healthy kids, 200 kids with chronic illnesses, published in JPEDS a few years ago. And the bottom line is if they estimated low bone mineral density based on DXA alone, they called quite a few more children, particularly the chronically ill children, as having low bone mineral density. When they looked at the results of the quantitative CT, which is arguably kind of the research gold standard, many fewer children were classified as having reduced bone density or a z-score less than -2. So they concluded that the inability of just a regular DXA without adjusting for this to account for the large variability in skeletal size and composition in growing children greatly diminishes its accuracy in this population. So how does this come into play with kids with Crohn's? Well, if you get that DXA of the lumbar spine, I mean, we know that you need to use age and gender z-scores, certainly not the t-scores that are used for adults. But, you know, many of our kids that are at risk for this, as Athos pointed out, have reduced height. And there are a lot of pitfalls that come into play in our patients who have reduced height for age and reduced pubertal development and delayed skeletal growth. And of course, a low z-score itself should not be a reason to start anti-resorptive therapy. And so this is just an example of what happens. You get your DXA with the z-score, your patient's 14 years old, her z-score on the DXA is -2.4, but once you actually account for her delayed bone age, you know, it's really -1.1. So, you know, we can try to do this in practice, but it's just something that we need to be aware of, that many kids you're going to get a report of a low z-score and it's not really low. Now the other issue though is even if the DXA result is accurate, does it predict your risk of fracture? Now we don't have this information in children with IBD, but there was a huge study published in the United Kingdom of 6,200 healthy children who had DXAs done when they were around 10 and then were followed for 2 years. And 9% of these had at least one fracture. So these are more kind of forearm fractures, not pathologic fractures. So essentially what they saw was that there was really only one DXA measurement that was slightly associated with future risk for fracture. But really, the bone mineral density was hardly different between the children who did not experience a fracture and those who did. Now, nevertheless, as your DXA went down, your risk for fracture went up, but the absolute difference was really, really low. Now, I'm not aware of this sort of study in pediatrics. I think it would be a little bit difficult to do, but this was a cross-sectional study that was done in adults with Crohn's, where they carefully looked for symptomatic and asymptomatic vertebral compression fractures. And I think this was kind of the key thing. Most of these patients had normal bone mineral density based on DXA. So they compared the individuals with the vertebral deformities compared to those without and with, sorry. And 40% in each group had normal bone mineral density, 50% in each group were within that t-score of -1, and then about 10% in each group were within that t-score of -2. So essentially the majority of these patients who had already experienced vertebral compression fractures would not be classified as being at risk based on only a DXA. And so they went on to do a different group did a multivariate analysis of factors associated with these vertebral compression fractures. And not surprisingly, it was the inflammation as evidenced by the CRP that was really most significantly associated with fractures, and really not the lumbar spine T-score based on DXA. So they concluded that just the screening on its own is not sufficient to predict the onset of metabolic bone disease, and that, as we all know, inflammation is really the critical factor. This kind of treat to target and other things that we've been talking about at this meeting. So I think we both kind of came to the same point, that it's multifactorial. There are nutritional components in terms of calcium and vitamin D. There's delayed maturation, delayed lean tissue mass, which is from inflammation and inactivity, and immune factors, and these all come together to reduce accruing peak bone mass by young adulthood. But I would argue that if we're treating somebody's IBD well, we're kind of addressing all these factors, and I don't know how much the DXA adds to that. So in summary, bone mineral density is often reduced in children with IBD. It may reduce their peak bone mass in adulthood. The low trauma and vertebral compression fractures can occur, but particularly, once they're adults. But, low bone mineral density, particularly by DXA alone, does not really reliably predict future fractures. And I think probably the message more is that we shouldn't be falsely reassured by patients who have normal bone mineral density at DXA if they have chronic inflammation, reduced BMI, the other risk factors that we've heard about. And so then, in fact, the DXA measurement alone has kind of a modest impact on our clinical management beyond what our optimal management already is. Thank you.